All right, folks, here we are. As promised, RT Complex Issues Made Simple, or RT CIMS, installment number 3. If you remember, we have been talking about the rules of mechanical ventilation, and we have talked about the first couple of rules, which included tidal volume. And now we are going to talk about plateau pressure and driving pressure and what these mean to you as the bedside clinician. I want you to understand that this might be the most important thing that we've talked about so far. So pay close attention, and we're going to go through this and get this done in certainly less than 5 minutes. So we've talked about in the previous installment about the ARMA trial, the ARDSNet trial, the ARDSNet group that did the ARMA trial, where they compared 6 milliliters and 12 milliliters per kilogram predicted body weight of tidal volume. And additionally, they paid attention to plateau pressure. In the study group, they kept the plateau pressure less than 30. In the control group, it was much higher. In this landmark study that's now 23 years old, and we've talked about the tidal volume targets, this tidal volume was further reduced if the plateau pressure was above 30 centimeters of water. So keep that in mind. If the patient became acidemic to a level that was inconsistent with the local standard, or whatever the clinician or the ICU team thought was appropriate, then the respiratory rate was increased in order to compensate for that acidemia, but the tidal volume was still left or kept below 30 centimeters of water. Now, in your mind, try to remember this respiratory rate increase issue, because it becomes more important later on down the line when we start to talk about mechanical power and energy applied to the lungs. When we talk about plateau pressure, we think that that number, a static plateau pressure, when all the flow has settled down and we get that static measurement, we think that that's a pretty good surrogate for alveolar distending pressure. So distending pressure is what we've always thought about in terms of barotrauma in a patient. We think that that plateau pressure is a good surrogate for whatever pressure the alveoli are being exposed to. However, there are things that influence that plateau pressure that may not have anything to do with the lungs. Morbid obesity is a big one. If somebody is morbidly obese and they have a BMI in the 60s, then you could expect that extra extrinsic influence on lung pressure is going to be sort of an artifact. It's not going to be a true reflection of what the alveoli are being exposed to. Other things that can cause this are intra-abdominal abnormalities like bowel edema, intra-abdominal compartment syndrome. How do we measure plateau pressure? As I just said, we have to take a static measurement of the plateau pressure. So we do an inspiratory pause or an inspiratory hold. And you can see in this graphic here, this is clearly volume control ventilation, where the pressure waveform and constant flow would look like a shark's fin. And you can see here that this plateau pressure has been measured, and we don't have numbers here, but it's significantly lower than whatever the peak inspiratory pressure would have been. Now, this pressure is much more important than the peak inspiratory pressure. This pressure, like I said, is thought to be a surrogate or a close resemblance of whatever pressure the alveoli are being exposed to. So driving pressure uses the plateau pressure in the formula. And you can see a change in pressure, or driving pressure, equals tidal volume divided by respiratory system compliance. Respiratory system compliance is tidal volume divided by driving pressure or a change in pressure, a difference between the lowest pressure and the highest pressure in a breath. So driving pressure in its simplest terms, this is the thing I want you to remember. Driving pressure in its simplest terms is plateau pressure minus PEEP. And I say total PEEP because some people do have some intrinsic PEEP or auto PEEP that you should be aware of. So another graphic, this is volume control ventilation. This is an inspiratory pause. This is a plateau pressure. This is a PEEP measurement. The plateau pressure minus PEEP is driving pressure. Big paper a few years ago, 2015, Marcelo Amato from Brazil published this paper that looked at, so this is a retrospective look. This is something that we're looking in the past at, but the retrospective look was at 9 papers that were prospective evaluations of patients with ARDS. So 9 previously reported ARDS trials. These were randomized controlled trials, and they're 3,500, a little more than 3,500 patients. So here is where the rubber hits the road here. We've already talked about how plateau pressure minus PEEP is driving pressure. And when they went back and they looked at all 9 of these studies and they collected data on PEEP, driving pressure, plateau pressure, tidal volume, and a lot of other data, what they realized was the closest thing that related to a risk of death or mortality was a driving pressure. And as I put this red arrow here, that driving pressure was about 15 centimeters of water when mortality or the risk of death precipitously went up. So to recap, plateau pressure is a static measurement that's done during an inspiratory pause. Driving pressure is the difference between that plateau pressure or that static pressure and PEEP. 15 centimeters of water is where there's a precipitous increase in bad outcomes. So we as clinicians should be for sure evaluating what somebody's driving pressure is every time we see them.